So our agenda today will start with updates on everybody's PDSA program projects. And then we're going to have, I think Dr. Bard will be joining us if he's not here yet. He'll be introducing our speakers, and one is from LASSO and the other is from Infant Crisis Services, and we appreciate them being here. So let's get started. Patty, are you here? If you would take over and talk to us about the smart aim for the parenting app PDSA and your measures, and if you have time, just the change theory diagram, which has been distributed to everyone. And that's what I'd like each of the programs to be ready to talk about: smart aim, measures, and change theory diagram. But we have to keep it short because we do have a lot of programs to get through and 2 speakers.
Can you see that information?
Yes, I see the change theory diagram part of it. It's part of it's kind of hidden off to the right.
Let me see. Okay, is that where's this thing? Why is it this way? Okay.
There you go. We can see that now.
Okay. So we're going to be testing the Positive Parenting app, and it's PAT, Safe Care, and 2 more sites. So the change theory is just developing that the app recruitment script. That recruitment pitch was delivery. Clients, actually, we had to recruit 5 for the first round, and then maybe it's going to be 20 for the second round. So we have done that. They've been entered into ETO. And once OU Health Science Center contacts the families and gets them set with the app, that's when we will start the check-ins with the clients to see if they have interacted with the app, any difficulties that they're presenting with the app, with the phone, with etc. So we believe that by the clients being engaged with the app, it will be an increased involvement in the child development. Those are the measures. And our change theory, our aim statement is just starting August 15 with the PAT and Safe Care programs. We'll recruit 5 participants for the first round and 20 for the second round to test a Positive Parenting app, and 20% of the clients will engage with the app at least three days per week. That's it, short and sweet. I guess part of the things that we've done is created the script. We did, the recruitment. We entered those 5 families and the NETO and the ETO touch point. So at this moment, we're just waiting for, the OU Health Science Center staff contacting families and getting the app in their phones. Maybe the first block in the road is that in order to be part of this app, they have to have an Android phone, and we just found these 5 clients with Android phones. The rest don't have it, so we're not sure what's going to happen with the recruitment of the other 20. And in other sites, I don't know if they had any issues recruiting families, but I'm not sure. I mean, we were told that they will be given a phone, but I don't know how that will work. If you have your phone, your regular phone, and then you have this just phone for this, I don't know if it's going to work, but that will be the entire thing. So I'm anticipating having issues because I would not do it having one phone and then the other. I don't know. I didn't hear because it's not my regular phone. I don't have it with me, so I can see that maybe not happening. But that's it.
Thank you, Patty. That's why it's beta testing, because that's what we want to do, is to find all of the problems. It's not about so much the outcomes as the process with this. Thank you. Now let's go to Oklahoma City C1. Do we have Sarah or Julie or Sally who could present?
Hi, good afternoon.
Hi, Sarah.
How are you?
Good, thank you.
Good. All right. Well, let me share my screen really quickly. Make sure I get to the right thing here. Okay. Can you see that? Okay. Is that fine? Okay. So for ours, we're essentially doing the same, the same layout that we did for our last project. That worked really well for us, except for this time, instead of looking at typical development, we're looking at atypical development. So our SMART aim here is to increase knowledge and comfort with atypical child development by 10%. So we have a pre-survey that we're planning to utilize with our nurses, and then also it'll be a post-survey after we provide education and training. And so our process measure will be the % of nurse home visitors that complete training in person or via video recording every month. And so our disruptor measures, just looking at staff turnover, number of staff who are missing trainings, but one of the things we're going to change this time is trying to record those trainings so that all of our nurses have access to them, even if they do have to miss those. And then that's kind of the main thing. And so our prediction, or I'm sorry, not our prediction, but this little section right down here, I can't remember what that was, but basically our goal, our idea, go ahead, Lisa, what were you going to say? You tell me what it is.
I was just going to say that's a primary driver.
Our primary driver, thank you. I couldn't remember the word, is just to increase workforce training on child development. So we still have a lot of our newer nurses with us. And that's, like I said, we felt like our last project was really effective. So we just kept kind of the same thing and just switched out the topic a little bit. So that's pretty much it. Does that answer all of the questions, Lisa?
I think you did great.
Okay,
I think it's terrific.
Okay.
Okay. And by the way, I just want to mention that all of your new ETO items have been sent to ANERA, except for one program that we're still tweaking the items. And so we hope to find out very soon that they're in ETO. So let's go to Cap Tulsa now. Is Ariane or Carolyn here? Hi, Carolyn.
Hi, I'm here. So are you able to see the screen, the developmental child referrals? Okay, perfect. So I'll have to give a shout out to Patty and LCDA, because really we were inspired when we had that last meeting and people shared what all they had done about that topic, and about really improving the process for referrals and follow-up of referrals. And so that's what we're focusing on this season. So we really want to have that really reliable process for follow-up on developmental screenings, and make sure that children who have delays are getting connected to the services that they need. And so our SMART aim is going to be for 80% of children with identified developmental or behavioral concern to be referred to services in a timely manner, and that 50% of the children referred are receiving appropriate services. And then we're trying to use the measures that we have there in ETO. And so we're looking at the numbers of the children who get the referrals that have scores below the cutoff. Then we're going to have them documented using that referral tracking touch point that's in ETO, and then also using that follow-up touch point to track the number of referrals that have been followed up on. And some of the things that we think are disruptors for that process often is that either the parent is believing that their child doesn't have a delay, and so refusing services for that reason, being too busy or not having the time available to follow up, or sometimes they're just waiting to receive the services, so waiting for that call from the service agency. And then on our change theory diagram, we really want to focus on making sure that the process is clear to the parent educators, so increasing some training during this time on the screening and referral process, and especially on those specific follow-up documentation. And then as we're administering the ASQs, that sometimes an at-risk child, a disruptor would be if they're not being referred to the service referred to the service. So we want to make sure that all children who are needing referrals are getting those and having those documented. And then that we are following up on each home visit on the process. And so then again, a disruptor might be that the parents are not receiving it, and we want to document why and overcome any barriers. And so we're hoping that we're going to improve our referral rates and the utilization of special services for the children who are needing that. That is it.
Terrific. Thank you so much.
Thanks.
Now let's see, Oklahoma City PAT Public Schools, Yolanda.
Can you guys see the screen?
Yes.
Okay. So first of all, I had to thank Lisa, because I mean, we have a few, I would say, issues when we were trying to decide how to get the change theory diagram. So, but we kind of continue doing complete the milestones and make sure that every child have a milestones completed. And when I say completed, is review in the visit with the parents, filled it out and recorded in ETL. That is the completion of the milestone. So not only to have it in paper, just to have it in the system. We thought that we want to continue with this because we have new parent educators, and of course we have been enrolling new families in the last few months. One of the changes that Liz did it with us is how to get the parent educators to get reminded about, you know, the completion of the milestones, and if I do in the supervision or reflective supervision, or if we have any other format that those reminders are in place. And of course, we also have been trying to collect the data, and that's the thing that we still are tweaking at it, collect the data about if those children are not completing those milestones or reaching those milestones, how we're going to get it. The referrals has been done in ETO. So what we ending, and I don't know if we're going to have any changes. We have a call later on, but the discussion about the milestones we completed, the parent educators will of course review and completed these milestones. If the milestones are, when you say milestone, also, you know, the ASQs, because we also see ASQs, they're not, I mean, we didn't say it in here, but that's also something that we take in consideration. If they're not, refer the child. And what we wanted to, of course, our goal is increase the number of children achieving the milestones, and with that is also increase the parent-child engagement activities. Disruptors that we can have is cancellations, or the parent educators are not completing those milestones. And another disruptor that we can have is families encounter issues when a referral has to be made. So, I mean, it can be that the referral has been done, but the family has not received anything for further, places that they say, well, your child qualified for services or any other issues that we may have. That's what we have for now. But again, we have a meeting set up in place so we can kind of decide it exactly how we're going to get this information from ETO. Is that correct, Liz?
Yes, that's right. We're going to meet tomorrow with Andrew, and we're going to just make these final little tweaks. And so thank you so much. PAT Bethany Public Schools. Amy, are you here?
Yes. Let me find it. Evidently, I have too many tabs open.
Do you want me to jump onto somebody else and then come back?
Here, I got it right.
Oh, okay.
Nope, that was the agenda. Yes, go ahead and go to the next person.
Okay. Okay.
Sorry.
How about PAT parent promise? Is Shauna here or Alicia?
I'm here.
Hi, Alicia.
Hi. Give me just a second. Let me see if I can. Can you see my screen?
No, I think maybe Amy needs to stop sharing.
Oh, okay. Am I still? Sorry about that. I didn't know.
That's all right.
Okay. Let me see. Oh, where did it go? Where did it go?
Good. Not the only one.
Sorry.
There we go. We
Did
see
it do
it.
it?
Yep, I see
Can you
change
see
theory.
it?
I see
Okay.
change theory diagram.
Great. Okay, so this time we kind of changed it up a little bit, and ours is actually going to be the diaper time is talk time. What we wanted to do is increase parent-child interaction through diaper time. So taking advantage of the diaper time when changing diapers, you know, to talk to baby and things like that. And so so we're going to ask parents, you know, about, you know, did the PEs discuss the handouts? First of all, you know, there were some handouts we found that can also kind of double as an activity type of thing. And so also asking parents who changed the diaper, who's having more interaction with the baby, you know, are they singing to baby while they're changing? Are they talking? There's just a lot of interaction that can happen during that time. And so what we're wanting to do is increase the involvement in child development. So of course the girls will be explaining, you know, the benefits of their interaction during the diaper time while they're practicing the activities. And of course we went ahead and we kept some of our disruptors from the last time. So for example, if the child is unwilling, if baby's a little too fussy, maybe they're not really wanting their diaper changed or whatnot, mental health, caregiver unwilling, lack of support, not having time, illness, or other were some of the disruptors that the girls came up with. And so it's pretty simple. I think that the girls are going to find it very fun to do. They were pretty excited, so we look forward to really getting started.
All right, fantastic. And you have a C1 program to thank for that idea. So this is another case of cross-pollinating between programs and sharing your ideas to help each other out. And I think that's just terrific. Amy, are you ready to take the screen? For PAT Bethany? There you go. Okay, we can see your PDSA. But you're muted, so if you're trying to talk, we can't hear you.
Okay, goodness, having all sorts of struggles, and I couldn't find my toolbar on top. Okay.
That happens.
I'm all out of sorts. Jem and I are already at the PAT conference because last year our flight got canceled. And so we said, we're not letting that happen again. We took the first flight out yesterday. So I'm out of my element here. But our smart aim, and my camera still, I apologize, does not work on this laptop that I brought. Our smart aim is by December 31st, 2022, for the children that have not reached their milestones, by discussing these milestones during home visits, along with explaining the importance of reading to their children every day, we will increase the number of times parents are reading to their children each week by 10%. And we also have smart aim number 2, Also, by December 31st, 2022, for the children that have not reached their milestones, by encouraging the parents to read to their children every day, the number of children that will reach their milestones on a future screening will increase by 5%. So our weekly outcome measures is whether the child is meeting their milestones for their specific age or not. The number of times each week that parents are reading to their child. Our process measures are whether the PE discussed the specific age milestones with family, and for our new families, providing reading materials if needed. Whether the PE discussed the importance of reading to their child every day in order to help their child reach their milestones at each specific age. And our disruptor measure, which I do apologize, my change theory diagram, I forgot to save it on this laptop. So
that's fine. Don't worry about it.
But I will go through some of our disruptors so you can get an idea of what would be on our change theory diagram. That parents do not read or use the provided materials. Parents do not have the appropriate materials to read to their child. Parents are not interested in reading to their child. Parents feel like reading in school is enough. Parents blame their children for not wanting to read. And we've got some examples there. They are not concerned whether their child is meeting their milestones or not. Parents do not think that reading to their children can help them meet their milestones. And finally, parents do not have time to read to their children every day. I think that sums it up.
All right, terrific. Thank you.
You're
All
welcome.
right, so PCCT PAT, Lena. Hi.
Hi. Okay. Screen. So our our SMART aim this time is by December 2022, our staff's rate of comfort regarding having hard conversations with clients about their child's development isn't in there, but it will increase by 20%. So when we were doing the just the discussion, it came to fruition that several of the parent educators were having some struggles with having difficult conversations with families regarding developmental delay possibilities, which really we talked about, and there's a lot of training for. So we're going to go through some training processes. Let me stop sharing that and go back to this thing right there. So this is the change theory diagram, increase the PE's comfort, having conversations, difficult conversations with clients about developmental delays. The parent educators will complete training on conversations about developmental delays. The parent educators will practice skills from trainings by talking to families about developmental delays. A disruptor is that families are not receptive to the conversations. And then we hope to increase the parent educators' level of comfort. And one more. It's this one here. Wait, I didn't do that right. Sorry, did I? No. There it is. Okay. Okay, so this is what our ETO touch points are going to be about and look like. Just the child development training touch point, discussing the training, and then child development PDSA touch point. Did you talk to the clients about possible developmental delay? Things like that. We're really looking forward to it this time. It's going to be a little different than anything we've done before because it's focusing on the parent educators this time instead of anything like about the children or families, so or fathers or etc.
Yeah, those tend to be really fulfilling PDSAs to work on too, and that you get a lot of buy-in and engagement from your staff. Thank you. Tulsa C1, do we have Michelle or Katie here?
Yeah, I'm here.
Hi, Michelle.
Screen. Do you see that change theory?
Yep.
Okay, so our goal is to increase nurse home visitor knowledge of child development by 10%, and we're offering some additional staff training. And so we've kind of handed that to the team to decide what they wanted, and they've come up with some really good topics in this last meeting that we had a couple of weeks ago. And we have complete knowledge pre-survey. So we've completed that step. We created the pre-knowledge survey of different types of child development, communication, fine motor, gross motor, social emotional development. So all of that is included in the pre-knowledge survey. And as soon as we are able to upload that into ETO, we will get those pre-surveys put in. And then we're going to provide 3 trainings starting in September, and then 1 in October and November. Then we'll do a post survey to try to measure that increase. Some of our disruptors were survey not completed by nurse. And then if nurse home visitor is unable to attend the learning session. So that's kind of where we are right now.
Okie doke. Thank you.
Sure.
And Dee Dee, are you here from Frontline?
Dee Dee is not here. She's at the PAT conference. So I apologize ahead of time if we do not hit all of your talking points, but Meg and I are going to do our best.
I bet you can do it. I have faith in you.
Thank you.
Okay. I'm going to share my screen really quick. Okay. Can you see that?
There you go. I can see the PDSA.
Okay, so our SMART aim is having PEs discuss and provide the Why Screening Matters handout on the purpose and importance of the age and stages questionnaire, the ASQs, will lead to a 10% increase in the parents' average understanding of the ASQs and the average rate of importance of the ASQs. And then I'm going to bring up our change theory diagram.
Yes, so sorry, Jesse.
Oh, you're good.
Yes, so yeah, our primary driver is to get the program. We want the PCG's knowledge to increase by 10% about the ASQ. What we'll do is develop a handout that's called Why Screening Matters. We'll give that to the client. The PCG will complete the ETO questions about their knowledge of the ASQ and its importance. The PEs will distribute the handouts and discuss the ASQ with PCGs. And the PCG's understanding, yes, again, that's the goal we want, is to have the knowledge of and importance of the ASQ to increase by 10%. A couple of the disruptors that you can see below are if the PCG was to cancel the home visitation and if PCG chooses not to participate in it at all. So that is that.
All right, thank you. I think we got a nice variety of kinds of projects for this cycle. Can't wait for you to start collecting data. That's the fun part for people like me. Okay, I'd like to turn it over to Dr. Bard to give us a few updates and to provide introductions for our guests.
Thank you, Lisa. Can you hear me okay?
Yep.
You can, okay. The first thing I wanted to do was to thank the PAT folks who are part of the Learning Collaborative. We met with Central Health Department staff about a month ago to review some of the feedback you had provided on the Learning Collaborative, amongst many other things that involve your operation. I wanted to just quickly flash on the screen, maybe a reminder of what that survey was about and some of the findings. Let me pull that up real quick. So for some of you, at least, I think this may look familiar. These were results from one item in particular about the learning collaborative work that we've done together, and some satisfaction feedback. In addition to the pie chart that you see here, which was a structured question, we also got some suggestions on areas where they'd like to see improvement. So as you can see, we've got some positive feedback, as you can expect, but we've also had some areas where we need some improvement. A few of those I wanted to call out specifically and let you know that we hear you, number one, and that we also intend to respond. So some of the response will involve the following. We would like to shorten the length of these particular monthly calls. I have to say that tongue in cheek today, because today's call is probably going to take our whole 90 minutes. But from this point on, we're going to shoot for 60-minute monthly calls. And one of the ways that we're hoping we can cut down the length of our monthly calls is to eliminate the amount of time we spend going over core measures in each of those monthly calls. So you're not going to see those today, and we'll probably only see them every other monthly call. We're also going to shorten the amount of time that we spend on each of those measures, really just hit the high notes of what we're seeing with the core measures, and then move right into the daily agenda or the monthly call agenda. Those who have been around since the beginning know that this is not the first time we've had to make adaptations on the fly. Right out of the gate, we were following what is still the standard practice for these learning collaboratives to conduct 2-day learning sessions. So the learning sessions that we have where we meet in person or we meet virtually, all of us, providers and supervisors, the COIN methodology for that actually stipulates a 2-day version. We learned after our very first attempt at that 2 days was not going to cut it. And so we have reduced all of that into 1 day. No surprise, we usually run out of time in those learning sessions, but I think it's functioning well enough, and we're able to get enough work done in those sessions and then follow it up as we did today with some review of where you landed with your next PDSA development. Fully intend to stay on that same pace, even as we transition out of this current learning collaborative on developmental monitoring and promotion and start a new PDSA process on the innovation project and referrals, bidirectional communication of referral information with 3 of our key referral network partners. That learning session, our next learning session, when we make that transition, will be scheduled for January of 2023. And we may attempt to cut some corners there too, just so that we can fit it all in as we close one down and open up yet another learning collaborative topic. Lisa, anything else I'm missing there that we wanted to touch on?
I think that was it.
Okay.
So if you'll just introduce the guests.
Yeah, so this is a good segue. Speaking of the innovation project, I think the agenda said updates on the innovation project. My update for you is that it's happening and it's almost here. And it is my pleasure to introduce one of our key partners in this project, somebody who perhaps does not need an introduction. Many of you may be well aware of Mr. Figgins, Director Figgins, who's joined us today. So I think I saw him on camera just a moment ago. I'll stop sharing my screen. Director Figgins has been at this for a long time. I was reading his bio just this morning. So he's been practicing in law for multiple decades now. I won't age him I won't out his age for him right before he speaks, but he's been around the block many times with projects like this, and he has a passion for it. Longtime director of our legal aid services here in Oklahoma, and before that, he served in similar capacities in the states of Arizona, and I think in Florida, and he was in Nebraska for a period of time. So he's got a wealth of knowledge on how we best serve the legal needs of the families and the clients that you care about and that you're providing home visiting services to. And we wanted him to come today to share a little bit more details about all of the benefits that are offered at Legal Aid Services of Oklahoma, and maybe even sprinkle in some information about what a referral looks like on their end as they receive it, and what bi-directional communication might look like through this innovation project that's ahead. Some of his wants and desires of information he hears back from agencies that he refers to or receives referrals from. So without further ado, Michael, welcome, and please take it away.
Thank you, David. And the multiple decades was very kind. I appreciate that. Hello, everybody. As David said, I'm Michael Figgins, and I'm the Executive Director of Legal Aid Services of Oklahoma. We call it LASSO. LASSO is a statewide entity with the responsibility of providing legal services to low-income people. Today, I want to talk about disparities and inequities in healthcare and development. And it comes from my observation that where people are born, where they live, where they age, where they work, drives health outcomes, and it drives health inequities. Basically, all those things shape a person's health, shape a person's development. Collectively, we term this as social determinants of health and development. This is something, these social determinants, it's outside of a healthcare provider-patient relationship. It's independent, yet it determines health. It determines health policies, and it includes systems that basically exist to perpetuate that poverty and that health inequity. So many times, I know healthcare providers, they just lament to me how often they treat somebody and they come back again. I fixed it once, it happens again, and it's a cycle that doesn't seem to have an end. So does access to justice, legal aid, have a role in health equity? Or why am I on this call? Well, I'm going to tell you why I'm on this call. I'm on this call to talk a little bit about what I call medical legal partnerships. It's not really new, but it's not really well known. It's basically a collaboration of lawyers and doctors. It wasn't long ago that in itself would have probably ended this conversation right there and then. But doctors and lawyers do work collaboratively. It's a strategy for supporting health justice, that is fairness in healthcare. And it involves legal aid lawyers who are special in the sense that they are poverty lawyers. They are experts in addressing the impact of poverty and fixing it and resolving it. They are powerful allies to anyone who's providing any kind of healthcare or any kind of development, whether it's to children or it's to seniors or everything in between. Legal aid, the poverty lawyers address the root causes of poverty, the systemic inequities, what's really going on, what's really happening. And in that context, expand institution and professional boundaries, what we can do together that we can't do individually, and learn new ways to not only practice medicine, but practice medicine and law together. So medical legal partnerships, well, they've been around for a while, but they certainly are approved by folks at HRSA, the folks at CMS, American Medical Association, and of course, the American Bar Association. And why are they so positive on medical legal partnerships? Because they work. They improve health, they improve well-being, they improve what you do, the outcomes that you're trying to achieve, and they certainly save on cost if the person's not coming back repeatedly. They integrate, that is literally integrate, legal aid lawyers directly into a healthcare development setting. They're part of the team. They're not somebody on the outside. They're there to help everyone to address the legal needs, the barriers to good health, or as we call them, health harming legal needs. So they're part of the team. They're like a specialist, like a cardiologist, like a pulmonologist. They're a specialist there to address legal needs and poverty. For example, food insecurity. You're going to see that when you visit homes. They may say that, they may show it, they may not, but it's there. Certainly they could get food assistance, they could get SNAP. Some try, they get denied. But if you have legal assistance, more often than not, that denial turns into an approval. The initial application turns into approval, and that's a source of food, nutrition, and food security that doesn't exist otherwise. Housing conditions. If you do a home visit and it's like, wow, it's really hot in here, or what's that smell? Is that mold? Did I just see a roach? What do you do when you see those things? What do you do when you see a leak or you suspect lead paint? All those are traumatic to the health of the individuals living in that home. They are also legal issues that legal aid lawyers can resolve. Whether it's a code violation, whether it's a bad landlord, legal aid can make that go away. Insurance denial. I applied for medical insurance. I applied for Medicaid. I'm having a hard time at Medicare. What do? Again, a medical legal partnership, that's the role of the poverty lawyer to resolve those issues, get the individual on healthcare insurance so that they can get the health care they need. Unfair employment practices, I can go on. Family stability, could be domestic violence, could be a need for guardianship. These challenges all involve legal advocacy. Let's call it law enforcement. And one of the biggest problems we have now is evictions, foreclosures, homelessness. All our legal issues can be resolved from a medical legal partnership. What the partnership does is leverage law, leverage policy, and addresses all those health, harming, legal needs. This has not been done before. It's new to some. To some, it's been around for a while. Structural barriers that perpetuate poverty go away. Medical legal partnerships fill educational gaps and contribute to a pipeline of professionals who are prepared to work together to solve health equity. And by this pipeline, I'm talking about everybody from the most experienced doctor to the community health worker, everybody in between, all part of the same team. Currently, Legal Aid Services of Oklahoma has 22 medical legal partnerships in Oklahoma. I'll just mention a few. It's the VA hospital, Variety Care, Mercy. It's also Stillwater Medical Center, Comanche County Medical Center, St. Anthony's, Hillcrest, Ascension, Cherokee Nation, the Oklahoma County Health Department, OU Schusterman Clinic, OU ABC Clinic, and the Mental Health Association and Red Rock, just a few who currently have attorneys embedded in their location. So in each case, if there's a medical legal partnership, legal aid offers training, intake forms, screening forms, so that people can ask the right questions to identify legal issues, all the referral protocols you will need, extensive issue training, the embedded presence that I mentioned, and it's integrated. Again, in most of these partnerships, the legal aid attorney is part of the healthcare delivery team. And the experiences I have, one of them is certainly the opportunity for consultations. Many times a doctor will just walk by, a healthcare provider will walk by the legal aid person in the actual facility and say, I had this client today, can you help me with this question? And of course we can. Social and economic problems with a legal dimension, if not addressed, will exacerbate or create worse health. And conversely, that ill health will then create more legal problems. It's not a good cycle. It needs to end. And legal issues, I mean, they are intertwined in most determinants of health. Law has largely been invisible up until the last probably 10 years. And that discourse, those interventions need to happen on a daily basis. Legal services has an essential role in mitigating many of the problems that your clients see, many of the clients that maybe you observe, many of the issues that perhaps they don't want to share because they don't know that you could help them. And what I am suggesting is that disadvantaged clients that you serve, as well as those who care, your staff as well, may not recognize the relevance of legal services, the legal process, the challenging situations that impede your ability to get the outcomes you desire. The law is a powerful tool for improving the lives of the poor and the vulnerable and ensuring that they have access to the critical needs that they have, healthcare needs, developmental needs, and entitlements, all prescribed by law. Legal aid tracks direct outcomes in each one of our partnerships, such as improved housing, or increased benefit income, or even intermediate impacts such as reduced anxiety or reduced stress. All of those make a difference. Legal aid, as poverty lawyers, has the knowledge, training, and skills to address all the legal needs that arise from a subset of health conditions. Let me give you an example of the models that used to be and the models that are now. Social pathogen, for example, poor quality housing, mold, what would happen? Well, the condition would probably be asthma, and the physician would most likely increase medication. Now, legal aid's there. Legal aid compels the landlord to get rid of the mold, increases the income for the family, and if necessary, relocates that family by asking for accommodations for other housing. Second example, person comes in with extremely high sugar in the blood. They have insufficient income to buy the right kind of food. They've been denied food stamps. Well, the condition is obviously malnutrition. The medical diagnosis may be supplements, but with legal aid on the job, there are income entitlements that legal aid will in place, SNAP, Social Security, appeal denials if necessary, obtain child support, unpaid wages, earned income tax credit, make sure the debts are not being paid that shouldn't have to be paid. Before you know it, there's more income in the house than there was before. So a medical legal partnership promotes an integrated key, services approach to address all those root causes that I mentioned. It's grounded in an understanding of the bi-directional link between law and healthcare. They go together, they complement each other, and respond to the complex legal healthcare needs of the people you serve. An MLP, medical legal partnership, advances the prevention agenda in both law and health. That's what it's all about, preventing things from going wrong. Reaching people at an early stage is so important in a medical legal partnership. Reach them before the mold makes the child really sick. So empowering and disadvantaging a vulnerable people to secure the services and protections is what legal aid does in a medical legal partnership. So you're probably all saying, wow, where can I get this at? I want this for me. Certainly, as Dr. Bart alluded to, the innovation effort is proceeding. LASSO is staffing up in recognition of that effort. Referrals, home visits, either legal aid can be at the home visit, legal aid can take a direct referral from the home visit. There will be forms for you to fill out to give to legal aid. And when staffed, we'll have people on site. We'll have a grant manager. You can contact any of them. And in the meantime, if you have a compelling issue right now, if you said, oh, I was in somebody's house yesterday and this is what I saw, you email me right now and we'll get on the case now. Any questions?
Thank you, Mr. Higgins. And I think it's wonderful that you mentioned the law is a powerful tool. My question is with this partnership, is it going to be any different with the requirements that LASSO has before? Like usually it's very rare there are clients that don't have documentation that can get access from your agency.
Documentation continues to be an issue. We can get around it in a couple of ways. If there's any evidence whatsoever of violence, trafficking, whether in the past or presently, legal aid can help. Certainly, if the person in question is a refugee, whether it's an Afghan refugee or other, legal aid can help. Other than that, legal aid can certainly make referrals and advise as best as we can.
Other questions for Mr. Figgins? Okay, I just want to say thank you, Michael, for your willingness to partner with us in this project, and then to the home visiting crowd here. You may not, you keep hearing medical legal partnerships. We're using that term medical broadly for purposes of the innovation project, right? So your healthcare workers, whether that's a mental health or physical health or all the above, what we're looking to do is to better serve the clients that you have currently, particularly in these areas of social determinants of health. And so the money that was put forward to fund our innovation project and all other innovation projects across the country, we had to address social determinants of health and health inequity. And it made a lot of sense for us to partner with LASSO in this project to accomplish that aim.
We've got a question in the chat asking about what services might be available for people in the LGBTQ community who can't find healthcare.
Great.
Well, if somebody cannot find healthcare, and again, until we're up and running, you should email me. There's no reason why the person you speak of should not have healthcare, whether it's Medicaid, whether it's Marketplace. As you all probably know, the CMS has a Healthy Kids Initiative. There's also the National Marketplace, and Legal Aid is the statewide provider for both of those programs. So we're really well versed in getting people health care, getting them insurance for health care. And if for some reason that person is otherwise being denied, that would be discrimination, and we will certainly act on that promptly as well. So I suggest you have them reach out to me, drop your name, and we'll do everything we can.
Would you mind dropping your email in the chat so that if anybody has questions, they could email you directly?
I will do that right now.
Thank you.
Mm-hmm.
If other questions arise, you'll have Michael's emailing, feel free to reach out to him. Feel free to reach out to us. We'll facilitate as best we can. We're in the contracting phase still of the innovation project, shoring up contracts, not only with Michael's group, but also with the new web portal. So Michael mentioned the forms that you'll fill out to make a referral to the agency. That will be available to you through this new web portal electronically and available to him so that we can have this bi-directional communication with this new secure web application. Okay, I think we're ready for the next item on the agenda. Lisa, so I'm gonna turn it back over to you.
Okay, our next guest speaker is Jennifer Bourne, and she's going to be telling us about a new project at her agency, which is Infant Crisis Services. So thank you for joining us, Jennifer, and take it away.
Thanks for having me. I'm Jennifer Bourne, Director of Operations and Finance with Infant Crisis Services, and I will give you kind of the history of our agency and what we do, and then the details about this new program that we have. We are a nonprofit organization. We serve babies and toddlers through birth through age 3. We were founded in 1984, and we have been going strong ever since. And this year, we're on target to serve about 22,000 babies. So it's a pretty busy, hopping organization. We're centered in Northeast Oklahoma City on Lincoln Boulevard. And then in 2013, after a lot of research and planning and focus groups, we realized that we have, Oklahoma City is so vast geographically that we were up against a pretty big transportation barrier for clients to get to us, because the needs that we meet are immediate and serious. If a baby can't eat, babies need to, if they're formula fed, they need to eat about every 4 hours, and diapers needs to be changed about as often. So it's an immediate need. So in an effort to address the transportation barrier, we developed a baby mobile program. And then in 2017, we added another unit. So we've got 2 baby mobiles, and we are able to kind of meet our clients where they are. We partner with other organizations, variety care, county health departments, hospitals, daycares, any place that is a good fit for us to come and help meet the needs of their clients. And currently we are in 23 counties throughout central, northern, and southern Oklahoma. So there's a definite need. And during the pandemic, we realized that the need was bigger than we even thought. And the pandemic kind of brought new people to us who maybe had never found themselves in a state of need before, because of all of the consequences of the pandemic. And then most recently with the formula shortage, that created a very big crisis for a lot of people. So we've been very intentional about getting our word out, about partnering with other organizations that are also able to get their word out and are reaching clients that would need our services, because we found throughout the years that a strong partnership is what really accomplishes your goals, because we need to all work together so that we can get our message and our product to clients that need us. And again, we are birth through age 3. We're providing a week's worth at a time of formula, infant formula, diapers, toddler food, and we'll do that 4 times per year for each child as they fall within that age range. And we offer those same services here at our main location, and then also on our baby mobiles. At our main location, we offer a few additional services. We have a car seat program, and we have a safe sleep program, and we offer fresh food. And those additional programs have kind of ebbed and flowed with our resources as far as availability of those items to order in bulk. And just with the pandemic, we've kind of had to change those up a little bit. But our core mission of food, formula, and diapers, we didn't miss a beat during the pandemic. We did change our service delivery model to a drive-through only service here at our main location, whereas prior we would have children and their families into the building and we could offer them additional resources and all of those other services that I mentioned. We have shifted to a drive-through, and again, if we've learned nothing, it's that we have to be flexible and willing to change. And we kind of realized that, okay, we can meet additional needs by doing drive-through only for working families who can't bring their child in, who don't have that kind of time. So now that things have kind of loosened up, we have a blended model where we'll do drive-through a couple of days a week and then in-person services. And then of course our baby mobiles are out 4 days a week throughout basically most all of Oklahoma. And what we're doing now, speaking of partnerships and how effective they are, Violetta Mumford with the State Department of Health and the Maternal Infant Early Childhood Home Visiting Program reached out to us and thought we would be a good fit for a new program that they have. So I kind of addressed how we do in-person services and we do on the go services through our baby mobile. All of the people that have received our services have become one of our clients. We would take their information, track them, offer surveys for outcome management. And with this partnership with the Violetta's program, is we're able to offer services in a different capacity that we're very excited about. We are going to provide supplies to all of the agencies that provide the home visiting services through her program. And we couldn't be more excited. It's a new service delivery model for us to act as somewhat of a diaper bank, somewhat of a formula bank, where we can get those items, because when you all go into people's homes, you can meet those needs. And as we've learned here, if those immediate needs are not met, you can't really go much further. So we're really, really excited about this opportunity, and it will kind of maybe open doors and open our eyes and potential to other partnerships like this as well. So that's really what we're doing right now. Does anybody have any questions?
Have you resolved the problems that had come up with baby formula and the supply chain?
It seems to be loosening up, and fortunately for us, as an organization, we're very thoughtful and intentional and kind of slow to move and make changes. We don't ever really stray from our mission. And so over the years, we've established some really great purchasing agreements, and we have this new building with large storage space. So we were able to start purchasing in bulk right before the pandemic hit, which was really fortunate. And we were able to bridge the gap as far as we never had a formula shortage here. And I feel like it's loosening up for the general public. It's still, it's still an ongoing issue. And that also can create a sense of need where there may not be an immediate need, if that makes any sense. But we've weathered it pretty well, and we feel like we're in a great position. And so that's why this partnership is coming also at a really great time, where that can really ease a lot of the stress and worry to know that we're kind of piggybacking onto your all's programs to really meet the client in their homes.
Yeah, that's great. I'm glad that you didn't have a big problem, that you were able to have your supply and deal with it when so many other places were, struggling.
Yeah.
Julie has a question in the chat. Could you tell us again what home visiting programs will be able to take diapers, formulas out to the home?
I think that would be me. So I'm Violetta Mumford.
Yeah.
I don't know
okay.
if you all have ever met me or seen me. I am behind the money So most of the contracts on the McBee side, John Delara is my supervisor, but he's usually the one that attends all of the meetings. So for right now, this initiative is for McVee families and McVee funded staff. I am going to work with CBCAP, so Sherry Trice, to see if we can get some funding to support our OCAP and our other C1 programs, because I understand that it is difficult when we only have, you know, the McVee funded families that can have access to those materials. And it's hard for me as well, because I'm like, I want to serve everyone, but the funds are only limited right now for the McVee families. But I will definitely work with CBCAP to see if we can supplement the funding and the contracts to increase them. That way all the families can participate. And I'm still fine tuning the process in which you guys will request it. The supervisors will be requesting the items in ETO from the diaper bank. So we'll have infant crisis services here in Oklahoma City, and then we're trying to get emergency infant services, is that correct? EIS up in Tulsa, and that way we'll have 2, and you guys would just go through ETO, make their request, it will send to them, it will be a pickup, and then once the home visitor provides the items to the family, then they would inventory it out in ETO. We'll get an invoice, we'll do it all again, either the next week or the next 2 weeks. So we do have a lot of initiatives. Yeah, does this include Tulsa and OKC? Yes. And we have a lot of initiatives coming you guys' way. So I have tried to make like a little infographic telling you when something is coming, like the name of the partnership, the timeline in which we expect it to roll out, so that every time you hear something, it's not for the first time, because I understand like that's hard. And I don't like when it happens to me. So I'm definitely trying to get something in writing. That way you guys know, like, hey, this is coming. It's for OKC and Tulsa. The supervisors will be in charge of doing this part, or we'll need your LIA staff, finance staff for this part for HDBAT. So we'll definitely have some more stuff coming your way. But the diaper banks, Jennifer was the first one. So I'm so excited. I think I cried because it's been a year. We've been working on this one a very, very long time. But yeah, so more information about how to request those items is forthcoming. So if you have any questions, please feel free to let John and I know, and we'll get it answered.
Yes, Violet. This is Yolanda with Oklahoma City Public Schools, and yes, we have MIECHV or MIECHV funding. I mean, that's pretty new to, at least to me. So if there is, you know, like anything like requirements, you know, the families that we can, how many we can get for, I mean, some kind of guidelines, because I mean, we serve, we have a big program, so I just want to make sure, you know, that everybody have a chance to participate.
Yeah, so the guidelines, like, you know, Jennifer just explained, like when the families go into her actual facility or to the mobile or drive-through, like they have their requirements with McVee. As long as we have money to cover, we want to provide something to the family. So if, like, I'm not putting a cap on how much we provide to the families. If a family is in need, I want to cover the cost. We have American Rescue Plan money. So this partnership, we have the first year that ends in June. I have 2 additional years at, you know, a few hundred, or a little over $100,000. So we have money to cover to provide what we need for families. Now, I also want to be mindful that this is a nonprofit, and I don't want them being out of pocket for a lot. So if I am looking at an invoice, I'm like, hey, we probably need to scale it back, because she has a business to run and other families to take care of that walk through their doors. So I don't want, you know, McVee monopolizing the time and the resources for her agency. So depending, and because it'll all go through me, I will definitely be monitoring how many requests we get. I will take a look at your current capacity report to make sure that it's reflective of what you're requesting. And if you get a new family, I may ask, like, hey, I see that you only have this many families, like, and you requested this many items. So, but we definitely want to take as much as we can to support our families. We don't want to, there's no cap right now. So if you need 12 weeks worth of stuff, or 12 consecutive weeks, I should say, not 12 weeks at a time, but we'll do it a week at a time, or however they can package it to us within reason. to not overwhelm them and not overwhelm your inventory or your storage needs. But yeah, there's no cap right now. There's no cap in how many times you can request items for families.
Is that only for diapers and wipes, or that's also formula and others? And is if a family is already getting services from infant crisis, is that different? Or do you have it in the database saying they already have 4 times of the year? So is that going to be different?
Yes,
it's different. Yeah, we're counting numbers with this program on our end. So they're not technically becoming clients of infant crisis services. So this is a separate program. And I do know that all the requests will go through Violetta for all of these.
Yeah, and that's going to be my next question. So, I mean, by the way, do we have already a ETO touch point in that, Violetta, or?
It has been created. I'm still fine tuning it to make sure that it captures everything we need. So I haven't rolled it out just yet.
Okay, no, I just wonder, you know, I have been off last week, so I just want to make sure that I didn't miss anything. But I mean, and my understanding is, you know, that we are going to be requesting this to you through the ETO touch point, and we are going to be the one delivering to our families, right? Is that correct?
Yes, so when you go and do the visit with the families, then you should be taking the items. How I thought about it, or how I pictured it, all of your home visitors would give you a list or let you know the needs of their families, and you would make one big request for your site. And then once I get their request, it would be filled by the diaper bank. And then once your home visitors go back for the next visit, they will give those items to the families, and then we'll do it all over again.
Other questions? Okay, thank you both so much. I really learned a lot about your services. This all sounds terrific.
Thank you.
I think it's going to make a really positive difference in a lot of families' lives. And it takes so much work to get something like this off the ground and reaching all the right people. David, did you have anything else that you wanted to say? I was just going to say that next month we're going to have a presentation from somebody representing Sooner Start, and then we'll have an update on how the beta testing has gone for the Positive Parenting app. And we'll talk some more about responding to the PAT survey and suggestions for improvements on what we do with you. David?
No, all of that and more in less than 60 minutes. It'll be lightning quick.
Yeah, but we're finishing up 15 minutes early, I'll have you know. So
and we bank that music next time.
This is I had a boss a long time ago who taught me you'll be popular if you always end your meetings early. So if there's nothing else, thank you everyone for your time, and we will see you next month.
Thank you.
Bye.
Bye now.